Good afternoon everyone. So let's begin with the MCQs. And the first MCQ which I have is, what is the most common ocular manifestation in mumps? It's a dastroretinitis, chorioretinitis, anterior uveitis, or it's a membranous conjunctivitis. So So what we are discussing here is basically it's a case of a mumps, and mumps, it's a viral infection. So the question which I am talking about is, what is the most common ocular manifestation in mumps? And the options are dacryocystitis, chorioretinitis, it's anterior uveitis, or it's a membranous conjunctivitis. So if you know the answer, you can just tell what is the most common ocular manifestation in mumps. So mumps, we have headache, myalgia, we have fever, we have, but it's caused by mumps virus. So if you can just tell the answer, it's a dacryocystitis, chorioretinitis, anterior uveitis, or it's a membranous conjunctivitis. So I'm going to tell the answer here is, it's a dacryocystitis. So dacryocystitis is basically what? It's inflammation of the lacrimal gland, as we know. So it is the most common ocular manifestation in mumps. So next we move on. The next question we have is, which of the following is not inherited in a autosomal dominant mode? So dacro was the right answer. So I'll just repeat. The next question we have, it's which of the following is non-inherited as in an autosomal dominant mode? And the options are erythropoietic protoporphyria, or it's a variegate porphyria, or it's acute intermittent porphyria, or the last option is hereditary coproporphyria. I repeat the question. The question is, which of the following is non-inherited as an autosomal dominant mode? And the options are erythropoietic protoporphyria, variegate porphyria, it's an acute intermittent porphyria, or it's a hereditary coproporphyria. So if you want to answer this. See, there are exceptions for all. Most of the porphyrias are autosomal dominant, and exception we have. So I'll just tell the exceptions here, and the answer here is basically A, that is the erythropoietic protoporphyria is the right answer here. And I will just tell what are the exceptions in case of autosomal dominant cases. So most porphyrias are autosomal dominant, except they are like ALA dehydratase deficiency porphyria, congenital erythropoietic porphyria, or it's a erythropoietic protoporphyria, or it's an H-linked protoporphyria. So you have to remember this, right? 4 which are autosomal recessive. Next we move on. It's calculation, I think. We have a patient, that is, you are conducting a study on birth weight. So as per your data, the probability of a baby having birth weight erythropoietic, you are there at least. Okay. So next we have, you are conducting a study on birth weight. As per your data, the probability of a baby having a birth weight less than 2500 gram, that is less than 2.5 kg, is 0.5, and of birth weight having 2.5 to 2.9 kg is 0.20. So what is the probability that the baby will have a birth weight of less than 3 kg? Options are 0.7, 0.6, 0.1, and it's 0.3. So here is a formula for probability. If you know, then only you can just answer. I'll just tell if that is, as per your data, probability of a baby having a birth weight less than 2.5 kg is 0.5, and having birth weight of 2.5 to 2.9 kg is 0.2. So what is the probability that a baby will have a birth weight of less than 3 kg? 0.7, 0.6, 0.1, or it's a 0.3? It's raining. Anyone wants to answer this? Okay, the answer here is A, that is 0.7. So here there is a formula. It's not a formula, but you have to add it. Like it's like 0.5 plus 0.2. It's like less than 2.5, that is kg is 0.5, and less than 2.5, 0.7. 0.7 is the right answer, because you have to just add it. 0.5 plus 0.2, that is 0.7. It's raining actually. You won't hear also what I'm telling now. So next we have, it's the formula was A plus B, that is 0.5 plus 0.2, that is 0.7. So next we move on. It's the fascia of which of the following muscles is involved in the formation of Alcott's canal? So if you know what is Alcott's, connection problem is not the connection problem, it is basically raining. So we'll move on. It's the fascia of which of the following, I'll just put it up. The fascia of which of the following muscles is involved in the formation of Alcott's canal? And the options are levator ani, obturator internus, external anal sphincter, or it's a gluteus minimus. Anyone wants to answer? The fascia of which of the following muscles is involved in the formation of Alcott's canal? Options are levator ani, obturator internus, external anal sphincter, or it's a gluteus minimus. See, it's very simple. They have just turned it out. It's basically Alcott's canal is basically it's a pudendal canal. So now if you can tell, it's a case of a pudendal canal which we are discussing, and which of the following muscles is involved in the formation of pudendal canal. So yeah, the option is I have just told, the answer is obturator internus. Obturator internus is the right answer here. So yeah, it is formed by the fascia of obturator internus. Am I audible or I am not audible now also? Hello, hello. Okay. So it's a Alcott's canal, that is a pudendal canal, and it is formed by fascia of the obturator internus muscle. So content, content of pudendal canal we have, it's the internal pudendal artery and vein, and it's a pudendal nerve. So basically its clinical significance is, it's like infiltration of a local anesthetic around the trunk of the pudendal nerve at the level of the ischial spine, which will result in analgesia of the lower vagina, posterior perineum, and the vulva. And it's like pudendal neuralgia can also occur due to compression of this nerve in the pudendal canal. So next we move on. What is the most common subtype of AML? That is the acute myeloid leukemia seen in patients with Down syndrome. So it's an easy one, I think. You just have to tell. I'll just repeat. What is the most common subtype of AML seen in patients with Down syndrome? It's AML M3, AML M4, M6 or M7. So yeah, if you want to answer this. Am I audible? Just tell yes or no, at least that much. So yeah, it's AML, M3, M4, M6 and M7. So what is the most common subtype of AML seen in patients with Down syndrome? So yeah, the answer is D, right? You have to just remember this, there is no choice. AML 7 is the right answer. It is the most common subtype of AML which is seen in Down syndrome. So yeah, that is the acute myocardial leukemia. Next we move on. The peripheral blood smear of a patient is shown below. All of the following can cause this except. So I'll just tell you what is the image they have given. It's I think I have to pause this, or am I audible? Yeah, M7. M7. Thank you. Surya Gandhi here. Okay, the next Q&A we have is the peripheral blood smear of a patient is given below. I'll just tell you what is the peripheral smear, and it is like it's a hypersegmented neutrophil. Okay, it's a hypersegmented neutrophil which is seen in megaloblastic anemia, as you know. So which of the following can cause this except? Options are vitamin B12 deficiency, chronic alcoholism, folate deficiency, and it's a orotic aciduria. So yeah, if you can answer, which of the following can cause this except? That is the vitamin B12, chronic alcoholism, folate deficiency, and it's a orotic aciduria. Yeah, hello. So yeah, anyone wants to answer this? Okay, I'll just tell the answer here. It's like B, that is the chronic alcoholism is the right answer here. See, in case of a megaloblastic anemia, you don't see chronic alcoholism. Basically, chronic alcoholism will not cause megaloblastic anemia. So it will cause non-megaloblastic anemia, that is microcytic anemia. So you have to remember this. And we all know it's vitamin B12 deficiency will cause megaloblastic folate also, and it's an orotic aciduria will also cause megaloblastic anemia. So the right answer is chronic alcoholism. Next we move on. It's the urine culture and sensitivity report of a patient with a UTI. Yeah, it's chronic alcohol. So yeah, next question we have, the urine culture and sensitivity report of a patient with UTI infection is positive for aminoglycoside resistant Enterococcus fecalis. What is the most common mode of this resistance? And the options are, yeah, it will cause thiamine deficiency, and that's why we give thiamine also in chronic alcoholism. So yeah, so the question was, the urine culture and sensitivity report of a patient with UTI is positive for aminoglycoside resistant Enterococcus fecalis. So what is the most common mode of this resistance? And the options are inhibition of transport across bacterial membranes, its production of inactivating enzymes, and we have low affinity of the bacterial ribosome, or it's a drug efflux mechanism through the membrane. So yeah, if you can tell what is the most common mode of resistance in case of UTI, which is positive for aminoglycoside resistant Enterococcus fecalis. So yeah, the right answer I will tell. I think I also don't know this. Okay, the answer is B. That is the production of inactivating enzymes is the mechanism for this resistance. So yeah, clinically the most common cause of aminoglycoside resistance is drug inactivation of enzymes. So yeah, it is commonly acquired through conjugation and transfer of plasmids containing resistant genes. So yeah, so basically the mechanism here for causing that is the aminoglycoside resistance Enterococcus faecalis is production of inactivating enzymes. So next we move on. A carpenter is there. Carpenter was diagnosed with a sinonasal carcinoma and planned for surgical resection. So which of the following histological varieties would be most likely in this case? Options are squamous cell carcinoma, adenocarcinoma, melanoma, or it's an anaplastic carcinoma. So I repeat, a carpenter was diagnosed with a sinonasal carcinoma and he is planned for a surgical resection. So which of the following histological varieties would be most likely in this case? Squamous cell carcinoma, adenocarcinoma, melanoma, or it's an anaplastic carcinoma. So if you can tell. It's a ENT question. NSLC is what? I think we are talking about last question. Okay, the answer is what is NSCLC? Okay, I will just tell it's a B. B is the right answer. No, melanoma is also not. Melanoma is not the right answer. Why? But why melanoma? Melanoma will have something like melanoma. Okay. Okay, the answer is not melanoma or it's not NSCLC. What I don't know what it is. The answer is basically adenocarcinoma is the right answer. That is B is the right answer. And workers of the furniture industry or woodworkers develop adenocarcinoma. So it is most commonly found in the ethmoid sinus and upper nasal cavity. And workers engaged with nickel refining may develop squamous cell carcinoma and anaplastic carcinoma. But in this case, when they have told you it's a furniture or it's a carpenter that they have told, you have to think of adenocarcinoma. And that too, the most common site is ethmoid sinus. So yeah, it's a adenocarcinoma. And next we move on, and we have a 35-year-old male patient was brought to the emergency department following a RTA. So on examination, he had multiple injuries over his body and was found to be in class 2 hemorrhagic shock. So the percentage of blood loss would be in between. Options are 5 to 15, 10 to 20, 15 to 30, or it's a 20 to 40. So it's a easy one if you know. I'll just repeat. It's a 35-year-old patient who was brought to the emergency following a RTA. On examination, you find multiple injuries are there over his body and was found to have class 2 hemorrhagic shock. So the percentage of blood loss would be 5 to 15, 10 to 20, 15 to 30, or it's a 20 to 40. So yeah, if you can just tell. It's a class 2 hemorrhagic shock. So there are basically from 1 to 4. There are 4 classes of hemorrhagic shock. So yeah, if you can tell the answer. Okay, I'll just tell. Yeah, 15 to 30 is the right answer. So yeah, 15 to 30% is the class 2 and it usually amounts to around 750 to 1500 ml of blood which has been lost by the body. And yeah, we have from class 1 to class 4. That is, if it is class 1, that is less than 15%. Class 2 is 15 to 30%. Class 3 30 to 40, and if it's class 4, that is greater than 40% is the class 4. So yeah, pulse rate also is there because you have to remember all that classification for that. So yeah, so it's a class 2 and they will have a mild shock with heart rate of more than 100 and it's associated with orthostatic hypotension and the patient is usually anxious in this case. So we'll move on. So next we have, which of the following statement is false about the Chidiac-Higashi syndrome? I'll just repeat. It's which of the following statement is false about Chidiac-Higashi syndrome? And the options here are: there is an aberrant phagolysosome function, it has an autosomal recessive inheritance, investigation shows neutropenia, and the last one is granules are absent in WBCs. So yeah, if you can just tell which is false about Chidiac-Higashi syndrome. Options were: there is an aberrant phagolysosome fusion, it is an autosomal recessive, its investigation shows neutropenia, and the last is granules are absent in white blood cells. So yeah, Gandhiji, where are you? Okay, the answer is D here. The D is the right answer. Granules are absent in WBCs. So yeah, so it's a Chidiac-Higashi syndrome. It's basically seen in peripheral. Basically, leukocytes are active and granules are seen in the seen in the cardiac Hayashi syndrome. So yeah. So others options were right. Right in the sense they are true for the condition, and that if there is an aberrant phagolysosome fusion, it has an autosomal recessive condition, and investigation will show neutropenia because leukocytes are present in the peripheral smear also. So yeah, leukocyte contains giant granules in case of cardiac Hayashi syndrome. So basically it's a defective fusion of phagosomes and lysosomes which results in phagocytes function and susceptibility to infections. So yeah, it's an abnormalities of neutropenia and all that. So I will just repeat, it's the granules are present, it's not absent in cardiac Hayashi syndrome. Next we move on. Which of the following side effects is most likely to develop in a newborn following BCG vaccination? Options are ulceration, fever, regional lymphadenitis, and it's a suppurative lymphadenopathy. It's an easy one if you can just tell. Which of the following side effects is the most likely to develop in a newborn after a BCG vaccine? So they are just asking what is the adverse effect. Ulceration, fever, regional lymphadenitis, or suppurative lymphadenopathy. Most likely, most common side effect. So yeah. Anyone? Okay, the answer is it's not fever, it's A. That is, ulceration is the most common side effect of a BCG vaccination. And yeah, following vaccination, the local tissue response begins and all that. There will be a scar formation and healing will be there within 3 months. And side effect most commonly seen include ulceration at the vaccination site, and there will be a regional lymphadenitis. But yeah, the most common will be ulceration in this case. So yeah, in an immunocompromised patient, it's a disseminated BCG infection can also occur. Next we have, which of the following is the first line imaging investigation done in a child presenting with an episode of UTI? So they are just asking what is the investigation of choice for a child that too having an UTI. Options are voiding cystourethrogram, micturating cystogram, ultrasonogram, or it's a DMS scan. So yeah, if you have learned pediatrics, you might be knowing. So what is the first line imaging for a patient for a child that too who presents to you with UTI? It's an voiding cystourethrogram, micturating cystogram, or it's an ultrasonogram, or it's a DMS scan. So yeah, if you want to tell. Initial imaging they are asking basically. The first line only, that only. What is the first line imaging in case of a child in UTI? Anyone wants to answer? Okay, the answer I will tell. It's normally you have to do a USG. If a child comes to you with an episode of UTI, so you have to first consider it for a USG. And when USG is abnormal, then you can do like voiding cystourethrogram can be done to evaluate the condition further. And DMSC also can be done after 4 to 6 months of acute infection. But when a patient comes to you at the first time, you have to do a USG in case of children. So yeah. Let's move on. It's and Herin's, that is the Herin's nerve finally relays in. Options are cortex, midbrain, pons, medulla. It's an Herin's nerve, that is HERINGS. It's an Herin's nerve finally relays in. It's a cortex, midbrain, pons, or medulla. So yeah, if you want to answer. It's a factual question. Okay, it's in the medulla, so you have to remember. You cannot just. So yeah, it's a Herin's nerve which finally relays in the medulla. So yeah, it's a Herin's nerve, then glossopharyngeal nerve, and then tratus solitarius in the medulla it goes. So it's a baroreceptor. It's from a carotid baroreceptor. It goes to the tratus solitarius in the medulla. Next we have, it's a long question. So yeah, we have is a 62-year-old man who was taken to a psychiatrist by his family with complaints of a strange behavior. So he has been inappropriately making sexual remarks and was caught urinating in the public. So recently he created a ruckus by cracking jokes and laughing out loud at a funeral. So on evaluation, there was a deficit in executive functioning and working memory. So what is the most common genetic change associated with the given clinical scenario? So yeah, the options are it's a nucleotide repeat expansion, it's a trinucleotide repeat expansion or deletion, or it's a point mutation. So just remember diagnosis in this condition, because I don't think you will be knowing this. Just remember diagnosing after this. So I'll just repeat it for the last time. It's a 62-year-old man who comes to a psychiatrist by his family, and he has strange behavior. What he does inappropriately making sexual remarks and was caught urinating in the public once. And recently also he was making a ruckus by laughing at the funeral. So yeah, on evaluation related deficit in executive functioning and working memory. So what is the most common genetic change associated with this condition? So yeah, first time what is the diagnosis, otherwise you won't be knowing this. Most common genetic abnormality you won't be know without a diagnosis here. So yeah, if you can tell. Okay, the diagnosis is suggestive of a frontotemporal dementia. So yeah, it's a case of a frontotemporal dementia, and the most common gene which is affected here is C9 over F72. But yeah, what it is, it's an Hessian nucleotide repeat expansion in this case. So yeah, you won't be able to tell the gene, but yeah, you can just tell diagnosis at least. And they will ask you like this only. You know the diagnosis, but you don't know the answer here. So yeah, it's a frontotemporal dementia, and that too it's an Hessian nucleotide repeat expansion. Next we move on. It's an radiograph of a patient with a history of injury to the hand is given below. So what is the likely diagnosis? So they are just asking what is a fracture. It's like Barton's, Schaffner's, Smith and Rolando's fracture. So I'll just tell what is the image here. The image here is basically it's a fracture of radial styloid process. So now just tell me what is the fracture of radial styloid process known as. It's a Barton's, Schaffer's, Smith's or Rolando's. Yeah, anyone wants to answer this? It's an easy question. It's an fracture of the radial styloid process. So what is it called as? It's a Barton's fracture, Schaffer's fracture, Smith, or it's a Rolando fracture. So yeah, if you want to answer this, I think you can, but okay, you don't want. Okay, the answer is it's B. The B is the right answer. That is the Schaffer's fracture because it's a fracture to the radial styloid process. And yeah, Barton's fracture, it's an interarticular fracture of the distal radius with volar subluxation of the wrist, and whereas the Smith's fracture, it's a distal radial fracture with associated volar angulation and distal fracture fragment, and Rolando's, it's very easy. Rolando is the interarticular fracture, and that too it's a comminuted fracture of the base of the first metacarpal. So it's very easy to remember. Just remember it's a Rolando, it's metacarpal fracture, that is the first metacarpal fracture. We have Smith, that is a distal radius. Barton's also but it's an interarticular. Barton's, it's also distal radius fracture. And Schaffer's, which we are talking here, it's a radial styloid process fracture. So yeah, called as Schaffer's fracture. Next we move on. What is the drug of choice for treating ethyl glycol poisoning? And the options are sodium bicarbonate, fomepizole, thiamine or ethanol. So I repeat, it's a question like what is the drug of choice for treating ethylene glycol poisoning? Options are sodium bicarbonate, fomepizole, thiamine or it's an ethanol. Anyone wants to answer this? Yeah. Okay, I will only answer this. So yeah, its answer is basically it's a B. That is the fomepizole is the drug of choice for ethylene glycol poisoning. So you have to remember it's ethanol only we give. See, for ethylene glycol we give ethanol, but yeah, we can also give what your preferred drug is fomepizole, or ethanol you can give, but if it is not available then. So yeah, fomepizole is the right answer. Yeah, B is the right answer. And it inhibits the enzyme alcohol dehydrogenase, and we can give other also, but drug of choice is fomepizole only. Sodium bicarbonate we can give for correcting the systemic acidosis. So yeah, next we have, in which of the following condition is the given X-ray finding seen? So I will just tell you what is the X-ray finding. You can just tell by that only. It's it shows a feline esophagus. So yeah, if you know a term feline esophagus in an X-ray, you can just tell what is the diagnosis. I'll just do the options. It's an esophageal atresia, esophageal stenosis, reflux esophagitis, or it's an Barrett's esophagus. So yeah, if you can answer this, it's a feline esophagus in the X-ray. Barium swallow you do, and it's a feline esophagus. So feline esophagus is basically also known as esophageal sieve, and they are folds that are 1 to 2 mm thick and run horizontally around the entire circumference of the esophageal lumen. So now at least you can just tell what is. Okay, the answer is C. That is a reflux esophagitis is the right answer. You see a feline esophagus, which I just told now what it is. It's a fold of that to 1 to 2 mm fold which runs around the esophagus horizontally, which runs around the esophageal lumen. So yeah, it can also be seen in hiatus hernia as well as esophagitis. But here they haven't given, so the answer is reflux esophagitis. Next we move on. It's OBG question. Yeah, it's OBG. No, it's not an OBG. Yeah, I'll just tell the question once. You are performing a CPR on a woman who is 38 weeks pregnant. So she was admitted to the emergency room after a massive pulmonary embolism had led to cardiopulmonary arrest. So despite adequate resuscitative measures, there is no improvement. So what is the cutoff time for perimortem cesarean delivery in this scenario? It's an easy question. So if you can just tell, I know this answer. So yeah, you are performing a CPR with a 38 weeks pregnant, and she was admitted to the emergency room after a massive pulmonary embolism and which had led to cardiopulmonary arrest. So despite adequate resuscitative measures, there is no improvement. So what is the cutoff for a perimortem cesarean section in this scenario? It's a 1 minute, 2 minutes, 5 or 3 minutes. Anyone? 1, 2, 5, 3 minutes only. So yeah, it's a perimortem cesarean delivery according to the AHA 2020 guidelines they have been given. But yeah, okay, the answer there is, if you don't want, it's C. So yeah, you have to wait for 5 minutes. If there is no spontaneous circulation, so you have to do a LSCS in this condition. So 5 minutes is the right answer. So yeah, perimortem cesarean delivery should be considered if there is no return of spontaneous circulation within 5 minutes. Next we move on. It's a skin biopsy from a patient with an immunobullous condition is shown below. So what is the diagnosis? So I'll just tell the image here. It's Thombstones. Yeah, there are a row of Thombstone appearance. So just remember, if there is a case of that is a pathological image they have given, it's a Thombstone appearance. So it is classically of which feature, which diagnosis it is basically. So now you can just tell. I'll just repeat. It's a skin biopsy which shows a row of Thombstone appearance and patient with an immunobullous condition. So what is the diagnosis? It's a pemphigus vulgaris, pemphigus foliaceus, it's a bullous pemphigoid, or it's a epidermolysis bullosa. So yeah, if you can just tell what is the condition which you have a Thombstone appearance in pathology, that is in the biopsy only, you can just tell skin biopsy. So yeah, okay, I'll only tell it's A. So you have to remember, whenever they tell you that is a row of Thombstone appearance, it's clinically, that is, it's not clinically, it's pathological seen in which condition? That is the pemphigus vulgaris. And you know pemphigus vulgaris, you know the anatomy and you know the pathology in this condition. That is, there is a suprabasal splitting of the epidermis leading to the blister formation. Yeah, blister formation is a clinical finding also, we see that. And the basal layer remains adherent to the basement membrane. Yeah, it's a pemphigus vulgaris only. And what happens in this, the basal layer remains adherent to the basement membrane and will give resemblance to the row of Thombstone. So yeah, Thombstone appearance is seen in pemphigus vulgaris. Adherent and basal layer is there. So yeah, next we have a 60-year-old woman is diagnosed with melanoma. On examination, a palpable lymph node was present in the posterior triangle. So biopsy you do, and biopsy reveals presence of tumor cells. So which of the following drug used to treat this condition is an MEK inhibitor? So yeah, if you can just tell, options are dabrafenib, vemurafenib, tarametinib, or it's a ipilimumab. So I'll just repeat the question. It's a 60-year-old patient who comes to you with who has a diagnosis of melanoma, and my examination is a palpable lymph node. What you see is that in the posterior triangle. So you do a biopsy and which reveals the presence of tumor cells. So which of the following drug used to treat this condition is a MEK inhibitor? It's a dabrafenib, vemurafenib, tarametinib, or it's a ipilimumab. Yeah, if you want to answer this. So yeah, drug of choice because they are asking for this condition. So yeah, I will just tell what is the case. See, melanoma they have already given. So whenever melanoma is there, and that too it is here and there, that is metastasis is there, so you will term it as a metastatic melanoma. And in case of a metastatic melanoma, the drug of choice is tarametinib. So yeah, tarametinib is a MEK inhibitor and it is a drug of choice in case of a metastatic melanoma. MEK is basically mitogen activated extracellular signal regulated kinase. Only to remember that, but yeah, it's like that only. So yeah, it's for a metastatic or unresectable melanoma. It can be used as a single agent, but it is more effective when used with a BRAF inhibitor like dabrafenib. So we have to use with both, but yeah, if you have only one answer, it is tarametinib is the right answer. Next, we have only 5 questions left. You have been asked to write the final report following investigation of a cholera epidemic. It's a PSM question. So basically you have been asked to write the final report following the investigation of a cholera epidemic. So which of the following will you not include in this report? Options are history of previous epidemics, usual number of cases that existed before the epidemic, it's a geographical distribution of the epidemic, or it's an incubation period. So yeah, if you want to answer this, I'll just tell. You have been asked to write a final report following an investigation of a cholera epidemic. Which of the following you will not, I repeat, you will not include? It is a history of previous epidemic, usual number of cases that existed before the epidemic, or it's a geographical distribution of epidemic, and the last one is incubation period. So yeah, if you want to tell, yeah, it's an easy one. Okay, the answer is D. That is, yeah, it's D. It's an incubation period. See, whenever you write a report at an PSM, and that too for epidemic, there is no need to write the incubation period, because incubation period is fixed for every disease. It is fixed, like from some to some day it will be there. So no need to write that report. So report is not required in this condition. Yeah, there will be a history of previous epidemics, usual number of cases that existed before the epidemic you can write, and also geographical distribution of write. But no, incubation period we don't write in this case. Next question we move on. It's match the following. Yeah, if you can, otherwise I want to tell the answer here. Match the following syndrome with their respective karyotypes. It's like Turner syndrome. Yeah, I think you can just tell this answer. Turner syndrome, Swyer syndrome, and then insensitivity syndrome. It's an MRKH. MRKH basically it's a Meyer-Rotinatsky-Kuster-Hauser syndrome. Yeah, it's a big one. So you can just match the following. Okay, Turner syndrome you can just tell me. Turner is the easy one. Others if you don't know, it's okay. Turner syndrome, anyone? At least tell that. Okay, I will tell if you don't want. It's a 45 plus H, so you know it's a 45 plus H, so that is a Turner syndrome, because there will be one deficit. It will not be double H, it's a H, so Turner is 45 plus H. So Swyer syndrome is basically it's 40. It's normal, I think. Yeah, Swyer syndrome is normal, that is it's a 46 plus HY. Then androgen insensitivity syndrome we have, it's 46 plus HY, that is also normal. And MRKH only we have 46 plus HH, otherwise both are normal only. So yeah, what you have to remember is very simple. Turner you have, it's a 46 plus HO, and that is MRKH is 46 plus HH. I will just tell what they have. So I also don't know what is MRKH. It's MRKH is basically it's a Mullerian agenesis, renal aplasia, and cervicothoracic somatic dysplasia. So yeah, it's a condition where testis is absent. So if a testis is absent, it is 45 plus HH, the karyotype in this condition. So yeah, Swyer syndrome is also it's a pure gonadal dysgenesis which occurs as a result of mutation in the SRY gene. So yeah, it is also lead to underdeveloped dysgenetic gonads, but it will be HY only. So yeah, just you have to remember it's a Turner HO and it's MRKH, it's HH. So next we move on. It's I think we have last two questions. It's a 75-year-old man with a prostate carcinoma presents to you with a PSA of 9 nanogram per ml with a small tumor focus. So his lesion story sets. So what will be your most likely management? PSA, you know, it's the prostate specific antigen, which they have given is 9 nanogram per ml with a small tumor focus, and lesion story sets. So what will be your most management? What will be your management? It's a radical prostatectomy, external beam radiation, brachytherapy, or it's an active surveillance. So now you can just tell. It's a clinical scenario. It is 75-year-old. That is a man with a low PSA. It's a low because normal PSA that is less than 10, you can consider it as a low PSA. So yeah, it's a low PSA, and lesion story also they have given sets. And yeah, so the answer, if you can tell, if you want to tell, you can just tell. There is a grading actually. Yeah, it's a grading according to the grade. Yeah, D is the right answer. Active surveillance you will do, because see, yeah, it's a active surveillance is done when there is a lesion story less than 10. When lesion story is 6, early stage it's a small volume disease on biopsy, or it's a low PSA that is less than 10, which I told you. So yeah, there is a grading and treatment according to that. I'll just tell very fast. It's when you have a low risk. So in low risk, you will do a radical prostatectomy if it is less than 70 years, and if it is greater than 70, you will do active surveillance, because 70 years is the thing. So yeah, intermediate risks, you will do a radical prostatectomy for less than 70 years, and more than 70 you will do a surveillance plus minus TURP and hormone therapy. and we have if there is a high risk, you will do ablation. You will do early and then ablation plus radiotherapy plus surgical treatment, and the last one is metastatic. In metastatic, basically you will give a chemotherapy with a palliative. See, remember, whenever there is a metastasis, you cannot do anything. But if it's a severe metastasis, so chemotherapy is the last choice. Radiotherapy also is there, but yeah. So if you have an early tumor, like small tumor anywhere, you can do surgery. But yeah, if they have given you it's a chemotherapy, just think it is a beyond case, that is a metastatic case. So yeah, next we have what is the dose of dexamethasone given for a fetal lung maturity? Yeah, it's an easy one. So just repeat, what is the dose of dexamethasone given for a fetal lung maturity? Options are 2 doses of 6 mg given 12 hours apart, 2 doses of 12 mg given 24 hours apart, it's a 4 doses of 6 mg given 12 hours apart, or it's a 4 doses of 12 mg given 12 hours apart. So yeah, if you can tell, dexamethasone dose given for a fetal lung maturity. Now just repeat, it's a 2 doses of 6 mg given 12 hours apart, 2 doses of 12 mg given 24 hours apart, 4 doses of 6 mg given 12 hours apart, and the last one is 4 doses of 12 mg given 12 hours apart. So yeah, you have to remember this. Anyone wants to answer this? Okay, I will tell. It's basically we have to give dexamethasone, that too for a fetal lung maturity. So basically we give that I think below 34 weeks. Yeah. When there is a less than 34 weeks, you come to know that the fetus has not matured, that the lung has not matured. You can give dexamethasone, and we can give a 4 dose. That is 6 mg. You will give 4 doses, and 12 hours apart you will give. That is dexamethasone. Yeah. So yeah, it's a maternal administration of glucocorticoids. It is advised in preterm labor when the period is less than 34 weeks, and we give a IM injection of either betamethasone or it's a dexamethasone. So yeah, next is the last question for today. The last question is, which questionnaire is used for the assessment of a patient who presented with the symptoms of angina? So yeah, suppose a patient comes to you with angina. So which questionnaire is used, or what question you will ask to that patient for the assessment of a patient with symptoms of angina? It's a ROSE questionnaire, ROSE, and we have an IPSS questionnaire, CAGE questionnaire, or it's a YTS questionnaire. So yeah, if you know, then only you can just tell, otherwise it's a ROSE questionnaire. I will not told the answer here. Okay, the answer is A, that is the ROSE questionnaire which we are talking about in the case of angina, for angina. Then we had IPSS, which I told. IPSS questionnaire is basically used for BPH. So whenever a patient is having BPH, you will use, that is IPSS. IPSS is International Prostate Symptom Score. And then we had the C, that is a CAGE questionnaire. CAGE questionnaire is we use in alcohol dependency. Yeah, it is used for the checking the signs for alcohol dependency. And the last one was YTS questionnaire. YTS questionnaire is for the tobacco use in patient, that is in the young people who use the tobacco products, that is to study the prevalence of a tobacco products among young. And what is the full form of YTS? So YTS we have, it's a young tobacco survey. So I repeat, it's a young tobacco survey for adult tobacco patients, CAGE for alcohol dependency, IPSS for BPH, and the ROSE questionnaire, which was the question for angina. So yeah, we have done 25 MCQs for now. So thank you so much for joining, and meet you at 11 o'clock. Thank you.